Good afternoon, everyone. Today we are starting another session. I will start with Dr. Veer Singh. He will be presenting on subfoveal cystic sarcosis, the curse of white pearl.
Thank you, AS, for this opportunity. We have the video. चला रहा है video?
Can you play the video?
I shall be presenting a case of subfoveal cystic sarcosis, aptly titled The Curse of the White Pearl. The 34-year-old female patient presented with diminution of vision in the right eye since 5 days. Best corrected visual acuity in the right eye was 1 meter and in the left eye was 20/20. The anterior segment exam was unremarkable in both eyes. On fundus exam, there was a live subfoveal cysticercus cyst or the cursed white pearl, which showed movement on subsequent fundus photos. On OCT, the cyst was lying bang under the fovea in the subretinal space. After neuroclearance, surgical removal of the cyst was planned. The surgical plan was to use a 41 gauge cannula to inject subretinal BSS and create a macular detachment. This is followed by PFCL injection to displace the cyst temporally and finally extract the cyst through a temporal retinotomy, saving the fovea. Now let's see how the surgery really went. Notice the subtle movement of the cyst on shining the light towards it. A large ILM peel was done. In an attempt to reduce the amount of post-operative macular drag that may result from a temporal extraction retinotomy, using a microdose injector and 41 gauge cannula, keeping an injection pressure of 6 millimeters of mercury, a macular detachment was created by injecting BSS in the subretinal space at a reasonable distance from the fovea. Notice the controlled, slow and steady elevation of the fovea and the cyst. Multiple site BSS injection was done to increase the size of the macular detachment. The aim was to have a large enough detachment so that an extraction retinotomy can be made as far as possible from the fovea. But the cursed pearl had other plans, and then the unexpected happened. While injecting subretinal BSS, the cyst just popped out of the fovea like an explosive volcanic eruption, and all my surgical planning went into the trash. Let's watch that again in slow motion. After a careful analysis of the cyst, I slowly approach the retina and, as I inject BSS into the inferior bleb, the fovea gives way, and the cyst erupts out into the vitreous cavity, forming a tiny macular hole. The cyst then casually sinks down and lands on the optic disc. I then use the cutter to eat up the cyst. I slowly approach the cyst on cutting mode and zoop, it went into the cutter's mouth. Since the iatrogenic macular hole seemed very small in size and the ILM had already been peeled, I was quite certain and confident that the macular hole will close. Air fluid exchange was done, 20% SF6 gas tamponade was given, followed by prone positioning for a week. At 1 month post-op, to my utter surprise, the best corrected visual acuity had only improved to 20/200. On OCT, the macular hole persisted and thus the curse of the white pearl had not been lifted. It was only after the first surgery I learned that I needed macular massage and an ILM graft to lift the curse. After learning the remedy, I took her up for a second surgery to close the macular hole and lift the curse. A silicone-tipped diamond-dusted Tano scraper was used to do gentle macular massage near the superior, inferior, and temporal edges of the macular hole. Additionally, an ILM graft was harvested from the edge of the previous peel under PFCL. Slowly and carefully, the ILM graft was then moved and positioned over the macular hole. After proper placement of the ILM graft over the macular hole, a slow air fluid exchange was done. To reduce the chances of any graft movement or graft loss, it is important that the air fluid exchange is done slowly. After removing all the fluid from the disc, the macula was dried as much as possible, making sure that the ILM graft stayed in place. 14% C3A-FIT gas tamponade was used, followed by 1 week of prone positioning. 1 month after second surgery, the best corrected vision had improved to 20/120. The OCT showed a closed macular hole and the outer retinal layer integrity was disrupted. And at 3 months, the best corrected visual acuity had improved to 20/60. The macular hole was closed on OCT, and the outer retinal layer integrity showed significant restoration with a small central defect left in the ellipsoid zone. To summarize, the patient went from having a subfoveal cysticercus cyst to developing an iatrogenic macular hole and eventually had the macular hole closed. She had a good final visual outcome as her vision improved from counting fingers at 1 meter on presentation to 20 by 60 after the second surgery. At last, the surgeon and his team emerged victorious and the curse of the white pearl was finally lifted from the patient. Thank you.
Thank you, sir, for the nice presentation. Any role of silicon oil, sir, in this patient, in the second
Not
surgery?
at all,
Can we
not
go
at all.
for silicon oil?
I mean, it's a clean, simple
Okay,
case.
okay, okay.
Small macular hole, even
Yeah.
in the first place. So even if it was extrafoveal, we don't use laser or silicone oil in cysticercosis cases because what do we do in laser? Laser kind of induces some sort of inflammation, and the cyst itself induces inflammation, even if it's extrafoveal. So you can just do a cautery, take out the cyst, and just leave it as it is. The retina will scar down, so you don't
Okay.
need laser there or silicone oil.
Oh,
Just leave it under air.
okay. Thank you, sir.
Thank you.
Moving on the next presentation, I would like to call Dr. Chaya Bharti. She will be presenting a novel technique of secondary IOL with 30 gauge needle. Can you increase the volume?
शुरू से दिखा दीजिए शुरू से दिखा दीजिए
MyXNet is a novel technique of doing scleral fixation IOL with 30 gauge needle. It's a modified form of XNet by Orolab. The technique 30 gauge needle is used along with 2 ml syringe and a stopper. Stopper is a piece of 240 band. Thirty gauge form of X is used along with two ml syringe and a stopper.
ओके कर दी मैं, ठीक है, थैंक यू।
MyXNet is a novel technique of doing scleral fixation IOL with 30 gauge needle. It's a modified form of XNet by Orolab. The technique .30 gauge needle is used along with 2 ml syringe and a stopper. Stopper is a piece of 240 band. Surgical procedure after completing vitrectomy. Markings are done 1.5 mm away perpendicular to the limbus at 3 o'clock and 9 o'clock position. Another marking is done at 1.5 mm away from the first marking parallel to the limbus. .30 gauge needle is inserted into partial thickness of sclera and progress towards the first marking, thus making a tunnel. Sclera is penetrated to enter into vitreous cavity. Needle is gradually progressed towards anterior vitreous cavity and brought out through the lip of tunnel. Tip of leading haptic of 3-piece IL is fed into the tip of needle and gradually withdrawn. As soon as the haptic is visualized, piece of band is gradually slipped into the haptic and haptic is withdrawn from the needle. In similar fashion, the trailing haptic is exteriorized. Centralization of IOL is done by pulling the haptics and bands removed. Haptics are trimmed and cauterized to make them blunt. Tunnel and conjunctiva sutured with 8O absorbable vicryl suture. These are few post-op cases. The result, it's a simple, easy, hassle-free technique with minimal bleeding, takes lesser time with no hypotony and can be done with readily available instruments. To conclude, it's a safe, minimal invasive technique which saves time, complication-free, glueless, less astigmatic, with faster wound healing, no wound leakage, no dependency on assistant, risk of slippage of haptics back into vitreous cavities negligible, economic. So the take-home message is it's a minimal invasive technique with faster wound healing and economic too. So say no to end-gripping forceps and glue. I have no financial disclosure. Thank you.
Nice video, ma'am. What is the duration of follow-up you have kept for the patient?
So till now, 2 to 3 years, I am practicing this technique.
Okay.
So since 3 years, I have been following my patients.
Any cases of haptic extrusion or
No, sir.
nothing?
No, sir. No,
Okay,
sir.
okay.
The patients are very happy and satisfied. sir.
Okay. Thank you, ma'am. So moving on the next presentation, I would like to call Dr. Devar Shah. He will be presenting on the topic the IOL Odyssey, the saga of surgical redemption.
Can we have the volume, please? No, that's not mine. I think you have opened the wrong presentation. No. My name is there, Dr. Devat Shah in your.
On a cloudy morning, a 62-year-old female with epilepsy got her cataract done at a nearby hospital. Unfortunately, she had an attack of epilepsy and she fell, which led to scleral tear with IOL dislocation in her only seeing eye. They operated the scleral tear, removed the IOL and placed a secondary SFIOL, but unfortunately that SFIOL also got subluxated. Hence, she was referred to us. On presentation to our OPD, the eye looked scarred from all ends. The superior conjunctiva was scarred due to the scleral tear repair. The 3 and 9 positions were also scarred because of the old SFIOL pockets. Hence, we were in an ocean of troubles with a near total aniridia, a subluxated 3-piece, poorly taken scleral sutures and scarring all around. And of course, this subluxated SFIOL. So what do we do now? How do we fix this situation? So the brain said, let's refix the same IOL in the area which is devoid of a scar.
Put a new IOL.
So the surgery began with a 2-port vitrectomy system. That is, one infusion port and the second port for instrumentation. So 2 conjunctival peritomies were done in the area that were absolutely devoid of any kind of scarring due to previously done surgeries. A refractive marker was taken and 2 holes were made exactly opposite to each other at a distance of 1.5 mm from the limbus. Now, partial thickness scleral pockets were made alongside the 2 holes with the help of a crescent blade. Since the eye was already vitrectomized, periphery was checked for any evident breaks. Now the tip of the haptic was held with the help of a max grip forceps, and that tip was taken out through the hole that was previously created. Now, to prevent a slippage of haptic inside, a silicone plug was inserted. The lens looked entangled on one side, hence a forceps was used to bring the lens in the center. But the lens haptic seemed to be stuck somewhere, either in the sulcus or in the ciliary region. Hence, an IOL tap method was used. So, if you see very closely with the help of the max grip forceps, the optic of the IOL was gently tapped, as a result of which the haptic that was stuck fell out in the anterior vitreous cavity. Once this haptic was absolutely well visible, the max grip forceps was used from the other hole that was made and the other end of the haptic was taken out. Since both the haptic ends were out, they were gently or snugly tucked inside the scleral tunnels or the scleral pockets that were previously made. Oh gosh, the IOL looked absolutely stable, and it was God's indication that yes, He had made it possible. To finish off the case, the conjunctiva that was opened was beautifully sutured, making sure the haptic is not visible at the end of the surgery. Once the conjunctiva was sutured at both the ends, both the ports were removed. The IOL looked absolutely central and stable. 1 month post-op, the patient came in with an improved visual acuity, with well-buried haptics and an absolutely stable intraocular scleral fixated IOL. The cornea, luckily, did not undergo any major decompensation. The retina was well attached, and in spite of having a mild foveal thinning, the patient was absolutely happy and delighted. Despite undergoing so many surgical procedures, her radiant smile shone brilliantly, transforming our collective efforts into a truly rewarding and a heartwarming experience. Thank you very much for patient listening.
Thank you. Extreme conditions, so required extreme measures. That's it.
Nicely done, sir.
Thank you.
Moving on to our next presentation. I would like to call Dr. Shirish Varghese. He will be presenting on double trouble,
I
recurrent
think
retinal.
Sirish is not there.
Okay. Okay, so I will be calling Dr. Jaideep. Dr. Jaideep will be presenting on the topic that sometimes pulling doesn't win you the tug of war.
I'll play it from here. Hello everyone, the title of my video is Sometimes Pulling Doesn't Win You the Tug of War. First video. Hello everyone, the title of my video is Sometimes Pulling Doesn't Win You the Tug of War. I have no financial disclosure. Many a times while operating a case of vitreomacular traction, by pulling at the vitreous, we end up developing a full thickness macular hole resulting in a central scotoma to the patient. So here I present a case of a 71-year-old lady with no systemic illness. She had a history of macular hole surgery done in her left eye a few years back. She complained of distortion and metamorphosis in 6 months, which was progressive. She was pseudophakic in both eyes. A pre-operative OCT showed a tabletop traction at the fovea with a vision of 6 by 12 and 10, and the other eye had a closed macular hole. A standard 25G pars plana vitrectomy was planned. After core vitrectomy, triamcinolone was injected to stain the vitreous. and careful dissection of the posterior vitreous was done around the macula to prevent any undue traction at the area of the VMT. The cutter port was always kept away from the center of the macula to prevent any traction there. 360-degree truncation of the vitreous was done to separate all vitreous attachment from the center of the macula and around the ONH. Careful induction of PVD was done on the nasal side of the ONH to prevent traction at the macula. After truncation, it was found that there was another layer of vitreous which was still present underneath, and so that was dissected too before we started trimming the area of the vitreomacular traction. After making sure all attachments of vitreous are separated, then the area of the vitreomacular traction was approached and trimmed. After this, peripheral vitrectomy was completed. After completing vitrectomy, fluid gas exchange was done and the ILM was stained with brilliant blue green dye, and ILM peeling was performed using a ILM peeling forceps. In this particular case, the ILM was peeled across the foveal center. However, fovea sparing ILM peeling is recommended to avoid full thickness macular hole formation. Thank you.
Thank you, sir, for the beautiful presentation.
Thank you.
Just one thing I want to know, whether we should put the dye under fluid or air, which is the better?
It's according your comfort. I think I prefer doing it under air because
Okay.
it stains better.
Okay.
So it's depending upon your comfort. If you are comfortable, because under fluid the staining is very minimal,
Minimal, yeah.
and if you can visualize the ILM, then it's all right. But I prefer doing it under air.
Okay.
That gives a better staining and better visualization.
Okay.
The only difference here was I did a complete peeling, but in cases of VMT, they say you can do fovea sparing
Fovea
ILM
sparing,
peeling, because there is a chance of iatrogenic full thickness macular hole. Even while you peel the ILM, you may accidentally
Pull it
cause
down.
a macular hole formation,
Yeah.
not just during vitrectomy.
Okay.
So some people say fovea sparing ILM peeling is a better option.
Okay. Okay. Thank you very much, sir.
Thank you.
So moving on our next presentation, Mr. Dr. Jayant Kumar, he will be presenting on incarcerated retina to a crumpled one tackling the troubles.
This video demonstrates the use of a combination of old, new and some innovative techniques to tackle This video demonstrates the use of a combination of old, new and some innovative techniques to tackle two difficult surgical retina case scenarios where the retina either got trapped or crumpled. Let's start with the first case. Traumatic retinal detachment with incarceration often mimics narrow funnel configuration on ultrasound, and the detached retina can even get crumpled and lie immediately behind the crystalline lens as shown here. These cases, however, need not always have poor visual prognosis and can have remarkable improvement. The first key point in the management is to support incarceration externally. As we can see here, the area of incarceration is externally isolated and inspected, and scleral pocket for 240 band is made 3 to 4 mm behind the site of incarceration to avoid direct compression by the band. Next point is external drainage of SRF before port making to avoid injury to retina lying immediately behind the lens. As we can see here, external drainage of SRF is easily being done, and hypotony following the drainage is managed by pulling all 4 brittle sutures tightly till globe is formed by injection of saline through pars plana. 3-port vitrectomy is then safely started. The third key step of surgery is releasing the incarceration and associated retinal folds internally. The extent of incarceration is first thoroughly assessed. The hemorrhagic clots impacted at the site are then cleared, and with careful use of cutter in momentary mode and use of mild suction and cutting alternatively as and when required, the entire site of incarceration could be released in this case as shown here. The released edges are carefully diathermized, and the remainder steps are then carried out like a routine case of retinal detachment, making sure of a thorough 360-degree barrage laser. This 30-year-old blind patient eventually had a best corrected visual acuity of 20 by 40. This tale thus proves that till an eye can perceive light, nothing is inoperable. The second case is about a young patient with macular tractional retinal detachment and a seemingly inoperable and crumpled posterior pole. The case was managed in a stepwise manner, starting with identification and circumferential dissection of the posterior hyaloid, thus isolating the macular tractional detachment with all its peripheral connections. BBG was then used and second membrane was carefully identified and peeled, resulting in smooth delamination of major bulk of the membranes. Gentle peeling was then extended circumferentially and extreme caution was exercised to avoid any iatrogenic break formation due to undue traction, as we can see in this part of the video. The membranes were then debulked with cutter and conformal cutter delamination was done till its safe execution was permitted by the membranes. This was followed by cutter assisted segmentation in the relatively avascular and taut areas. Repeat BBG staining was done under partial FA, followed by meticulous removal of ILM and overlying thin membranes. This step requires a lot of patience, and the same was exercised with all due care. Careful cutter delamination of the remnant membranes was then done, and the case was then closed after fluid air exchange and silicone oil injection. The post-operative fundus photograph and OCT clearly demonstrate a successful anatomical outcome in the case, with relief of all traction points and partial visual improvement. Thank you for watching this video. We thus conclude that trapped or crumpled retina can have good surgical and visual outcomes too.
Nice video, sir.
Thank you.
Actually, the first patient had a history of trauma, sir.
Yes, yes.
Okay.
He had a road traffic accident and bilateral vision loss. Somehow he could never come to a retina specialist till 1.5 months. When
Okay.
he came, he was no PL in one eye,
Okay.
and other eye was like that, trapped and crumpled and like incarcerated retina.
So you have intervened after 1.5
Yes, 1.5
months.
months.
Okay,
1.5
okay.
months.
The prognosis is also very guarded after you.
Yeah, months. Somehow he landed up with 612 vision.
Okay,
But
okay.
he was lucky.
Okay, great, sir. Thank you,
you.
sir. So moving on to our next presentation, Dr. Somak Madumdar. He will be presenting on sub-silicon oil ERM removal, a newer technique for early post-operative ERM. Dr. Somak is here. The next presentation will be done by Dr. Sanskriti Prasad. She will be talking about stitching vision together, CMT flex, foldable secondary IOL.
Good afternoon, sir. Sir, actually, because of some reason, the audio is not playing on my video, so can I give a voiceover?
Yeah, yeah. No problem. No
Thank you,
problem.
sir. Good afternoon, everyone. I will be speaking about stitching vision together, CMT flex foldable secondary IOL, a sewing machine technique for iridodialysis repair. A 59-year-old female presented on post-operative day 6 of left eye SICS with complaints of diminution of vision, photophobia, and a large iridodialysis with a post-surgery BCVA of hand movement close to face. After initial medical management of 6 weeks, the patient was planned for pupilloplasty and secondary IOL. A superior 180-degree conjunctival perit. As we can see, the needle is passed like a sewing machine to repair the iris. After we were sure that the eye's defect has been repaired, we tied the end of the loops. The knots were buried under the scleral flap. After the repair of the iridodialysis, next we went to correct the surgical aphakia that was post SICS. A sclerostomy site was made with 26 gauge needle and a small incision tunnel was made using keratome. The sclerostomy sites were made under the scleral flap. The CMT Flex hydrophilic foldable lens were put using Pranif T Flex and Nishi grasping forceps, and haptics were bought out of sclerostomy site. The handshake technique was used as the Pranif T Flex forceps has a broad non-traumatic tooth end and the Nishi grasping forceps has a crisscross broad end. The handshake technique was used. The haptics were bought out of sclerostomy site as the CMT Flex lens has a T-shaped junction of the haptic and the lens. Following that, the conjunctiva was reposited using fibrin glue. The post-operative patient had a best corrected visual acuity of 6/18 and round pupil with no other complaints of photophobia and other associated factors. Thank you.
Nice video. Any late post-operative complication you encountered with?
No, not yet. The patient is subjectively also comfortable. We achieved a BCVA of only 6/18, but no other complaints.
So have you checked why the BCVA was 6/18?
The fundus is normal, so we have not found any particular reason.
For how many days you have followed up the patient?
We followed up the patient on post-operative day 1, then post-op week 1, 3 weeks, and 1 month. And then after 3 months, we have called the patient.
Okay. Thank you very much.
Thank you.
So this will be the end of the session. Thank you very much.